I will have first questions to Thierry. I would like to ask you, as I mentioned after your presentation, I'm really waiting for the possibility of outpatient pulmonary care of physiotherapists in Poland, which is badly missing. And I think it's probably not only Poland, this probably block of countries is missing that. And from my experience working abroad, I think there is something connected with the language, because I saw it in French-spoken countries. It's really quite well organized. I saw France and Belgium. And if we're discussing Simeox, I would like to ask you, how do you do with introduction to the patient? I know you use it having this outpatient care, you may use it in physiotherapy, but if the patient getting the equipment, is any kind of set of training they must fulfill before they use it on their own? Because anything which is working, well, they also always some danger, especially with advanced disease. So could you see how is the protocol to get equipment? How many sessions? How long training?
The protocol is a hospital-based protocol. So all the sessions will be done during the hospital outpatient in the hospital setting to perform the maneuvers and to perform also spirometry, plethysmography, etc. So the protocol includes 3 training sessions, 3 days of training, and then 2 days of supervision by the physiotherapist. Just supervision, not a full training. And it's the same in the autogenic drainage arm. But the protocol is not designed to evaluate outpatient practice at home or in the physiotherapist.
And how does it work in practice? So forget the protocol and start it. Now there is Simeox owned by physiotherapy practice, and the patient is coming and the patient is having a session and training, and then I guess French insurance probably it's possible to get the equipment reimbursed. But before they get at home that, it's number of hours of training in outpatient care?
Maybe Gaucher would answer more practically. We don't know what reimbursement will be. That's the first problem.
Oui. It's not very complicated to use Simeox. I think the first sessions is the most important, because we have to evaluate the patients and to control the quality of the pump, respiratory pump, to evaluate the quality of inspiration and exhalation, and is motivation. That's right. Sorry for my English. And after that is the position of the mouthpiece is very, very important, and open glottis, and the evaluation of the tidal volume, and where is the tidal volume in the vital capacity, because we have to move the tidal volume in the vital capacity to visit the lungs and to be able to repair, to identify feedback of the presence of mucus, quality of mucus. And no technique is optimal if we have no prepare the mucus. It's why in allotherapy, movement, stretching, and so on are very important. And we have to introduce Simeox when we are sure that the patient is ready for a therapy session. Okay? It's why we use autogenic drainage, because we have to teach the patients to be able to put air behind the mucus, to improve the alveolar pressure, and to obtain the best exhalation as possible, superior, best side, and in complete relaxation. And when you have in your mind that protocol. I remember what say the professor, it's the contact between the physiotherapist and the patients. The relation is very important because together we are able to move the mucus, to feel the mucus, and to improve the quality of the sessions. And it's why the first and second, first session are very important. After 3 or 4 sessions with a physio, patients is able to do Simeox alone. Why? Because he feel rapidly where is what tidal volume is necessary to move the mucus at in the good part of the lungs. Okay, and I have a lot of COPD patients who come in our center for 2 sessions per week, 2 or 3 sessions, half an hour with moment of relaxation, okay, to be quiet. And for my CF patients, it's every day. And we have a patient from Paris who have now the device at home, and the results are very efficient. I hope I have answered to your question.
Yeah, thank you very much. Yeah, there is some.
Can I ask another question to Dr. Thierry about the protocol? You were speaking about the protocol of comparison autogenic drainage to Simeox, and there is a 2 days washout. Do you propose to, for during this washout for CF patients, not to do any physiotherapy at all?
I think it would be during weekends. So they usually do for physiotherapy in the physiotherapy. Yes, as a break. Yes, to wash out the effect of physiotherapy, and 2 days seems reasonable for this. Yeah. During the weekend.
I think it's working, my micro. When I saw what was exposed about cystic fibrosis, and I know the French school is far away in this domain, my question is, how long must be the Simeox therapy before lung transplantation? Because I think it's a very important thing for the people here in the room. And I have also a comment. Probably we had here a variety of cases: fibrosis, UPD, bronchitis, cystic fibrosis. And if I'm looking to what Professor Śliwiński said about fibrosis, it's a little surprising for me to see the benefits of Simeox. But I have some explanation. Of course, in COPD, it's a deflating effect, and the clearance of mucus is very important. Probably in fibrosis is also this diminishing of resistance, because in this fibrosis we have bulla of emphysema, and it's working also on this emphysema bulla with Simeox therapy, I suppose. What is your impression, the specialist?
I absolutely agree with you that there is always some level of emphysema in those patients. So no doubt that this might explain the effect I already have shown. But I have a rather more general question at this point of development of this story. Do you think that, especially I have a question to you as a man just on the field, do you think that this therapy is more efficient in under your supervision, or is evenly efficient when you allow your patients to practice at home on his or her own? So is supervision by physiotherapists bringing a new benefits, is more efficient than when patient is just performing the rehabilitation alone at home? Because this is very, very crucial. Do we want to use the machine in hospital, in the laboratory, in the outpatient clinic, or it should be used or maybe used at home?
I say that to start is very important to be in control with physiotherapists. And it's like in allotherapy or aerosol therapy. A lot of patients think that they do it well. And when you control, you have to correct, and we have always to correct something. And I think in the future, patients are autonomous with the device, but sometimes it will be necessary to have a control by a physiotherapist every 2 weeks or every month, I think. To teach, it's always to repeat and to control, to evaluate, to motivate, because for the drainage, the motivation is in the result of expectoration. And easy expectoration, without fatigue, in good relaxation. And it's not in a recipe, right? And I think we don't think that in the future we give the device with a procedure writing to the patients, or now we have to.
I have expected
Yeah.
just this answer.
Yeah.
Because if I always have in mind COPD patients who always have a huge problem with inhalation, with inhaler therapy. And we use the mouthpiece as well in this case, and that's what I expected. Thank you.
Thank you.
Yeah, Professor? Yeah.
Probably I can say something about all the measurements we did, because I think the most important thing is the adherence and compliance with the therapy and the quality of the sputum. When we measure many other information, some of them are confusing. Especially in our study, we saw that somebody had better saturation, somebody had improvement of FEV1, and some of the patients have even increase of residual volume. I cannot understand it just now, especially on COPD when we want to do some science. We have to choose between the phenotypes. Phenotype of chronic bronchitis probably is a good example. He could have profit. The phenotype of emphysema, I'm not sure, but in reality, patients are mixed. So I'm going back, forget the science, and go to the good the compliance of the patient and the device.
Yeah, Professor. Yeah.
Can I have also one comment? Maybe also that what I found with the use of the Simeox, the crucial person exactly is the physiotherapists. Because we as a doctors, we can indicate this method, but how the first session and how it will be controlled, and because the physiotherapists mostly know the patient, but yes, this is how the adherence and compliance between the patient and the physiotherapists works. But and the second and the most important maybe as in Slovakia, but I think in most of our countries is the greatest problem that the respiratory physiotherapy is relatively underdeveloped, or is not the priority of the physiotherapy. So that this is the greatest problem, because we do not have enough staff, enough trained physiotherapists in the field who will work with the patient at the ambulatory care. We all are here from the hospital. It was done by the hospitalized patient or so. So the necessary, it will be that also to speak about this method also with the students of the physiotherapy, in the universities, and so that they will know that something like respiratory physiotherapy exists, because this is the greatest problem from my point of view. Thank you.
Yeah, Elena. Yeah.
There's one thing regarding what you said about the problem with ambulatory care. If we speak about cystic fibrosis patients, they're very young patients who are very open to all new methods. And probably there will be also a place of online treatment, because in CF patients there's a cross-infection also that has to be thought of. So probably having the device like this, it will be easier to have a contact between the patient and the physiotherapist using the online technique as well. I suppose we should think about that as well.
Professor. Yeah.
I will only comment, yes, it will be. By the COF patient, it's accepted because they accept that they need to do this respiratory physiotherapy. But we know our COPD patients, they like, for them is the smoking at the first point, and then there are all other situations.
Too much.
I was very interested by your studies on COPD with some significant improvement in lung function. If we want to see the compliance, why not be very ambitious and design the study with a long-term study, 1 year in patients with both chronic bronchitis and frequent exacerbations via usual care. But it would be a very ambitious study. Do it.
Coming back a little to the technical problems, my question is, because I saw in some countries we had session of 15 minutes, 20, 25. What is the final recommendation after we are prolonging this session? Can we force the patient until 30 minutes of a session, or we have to define a standard session minutes duration?
I think really it's the feeling of the patients, because we know now the time the mucus move in the lungs. It's normal people is 2 millimeters per minute. It's very long, and yes, sometimes patients are motivated to do sessions too long, and we have to control that. And I like to change position, and I do 4, 5 sessions, no more. I think 10, 15 minutes, it's enough, really enough. Because fatigability is very important in COPD and CF patients. And after, the quality of cough depends of energy of the patients and the quality of the resistance. It's why I'm very interested by the evaluation of the resistance. Because we have to decrease resistance and no increase. And when the patients work too much, it's like song or cry, or they increase their hyperreactivity and so on. And for me, the most important is the feeling of the patients. And when I have a COPD or fibrotic patients, I have these patients in my center. And when they come and they say, Mr. Gaucher, I come for Simeox only today. I say, okay, it's good. And they use it, and they come only to use it. And I have in treatment a surgeon, with a very, very important distinction, hyperinflation, okay? And it comes to be deflated. I can prove it now. And I hope in the future with Dr. Perez and the team to be able to evaluate that and to chercher more the solution to deflate our patients with this Simeox.
Yeah, speaking about COPD patients, we have mild, middle lung function restriction and very severe disease. And we are looking in all the countries to identify very early with COPD, but we didn't succeed because in the hospitals they are coming usually severe cases. It's the first time when they are presenting, it's the first moment of diagnosis. And looking again to what you said about session, after your impression, this pioneering method is an opening window for mild COPD to have longer session of Simeox in comparison with severe disease, where you said, and I agree with you, the fatigability, the fatigue of muscles are more evident. What is your impression? Je peux vous dire en français. Alors, oui, ce sont différentes formes de BPCO. C'est la forme très facile. Ici, on peut prolonger les sessions de Simeox parce que probablement il supporte bien. C'est pas la fatigabilité musculaire si évidente.
I don't think that is la longueur, the length of the sessions that do it optimal. I think it's the quality of each inhalation and exhalation. It's why we use a pause, a good inhalation, and a good exhalation. It's not in the length, okay? And sometimes very surprised. A lot of physiotherapists think that COPD are not encumbered. They say they don't never cough, but never spit. But I think they don't spit because the mucus is very deep in the lungs and not able to be moved. And with Simeox, I'm sometimes very surprised to collect a different mucus, quality of mucus, with a different color and consistency in COPD, very gray and stick. And after the patients feel well, okay? And it's why I think we have to work with my colleagues in physiotherapy on the quality of the session, because we have to integrate in the life, in the daily treatment, the performance and optimal and not maximal treatment to improve adherence and compliance. Okay?
Yes, it's a good point. If I can add, really, I think that the interaction between physiotherapist and patient is the most important thing. But I agree that study is necessary. So I want to ask, in the meantime, what about the measuring the compliance? Is it possible to add some device to Simeox to measure just the time when it is used to really be able to measure the compliance, and then when to start how to improve the compliance in COPD patients? I think it's good when we start after some severe exacerbation, because in this time, patients with COPD really accept that something is happening and something has to be improved. So what about the start? How can you do it?
The Simeox will be in a few months, I hope, connected, and we will have a follow-up of how many times, the frequency of the uses of the patients. So I think the goal of that is to correlate the number of use and the improvement of lung function and also exacerbation. But this is just to have a register of patients. I think we have to do studies, randomized studies in many centers on many patients to prove it.
So thank you. Yeah, I'm afraid we have to finish. I would like to thank everybody for excellent discussion. I think it may continue, but we must free the room as well. And I think discussion is showing it's a very complex problem. Yeah, we got an excellent equipment, but we need motivated patients. We need qualified physio and a very good relation physio patients, and we need to improve and modify our system a bit to allow it within the system to happen. So I think thank you very much, excellent specialists, for coming, for sharing. Thank you everybody participating, and I think that we may continue the work together in different areas and really make studies a bit bigger and more significant scientifically. But it was great to see all these case presentations from practical point of view. Thank you very much.